Thank you for joining us for the second annual Global Summit, Global Kidney Innovations, Expanding Patient Choices and Outcomes, a collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is Dan Abel, and I'm a small business owner in West Virginia. I've owned and operated my own business for more than 35 years. The coronavirus pandemic has been challenging both as a business owner, responsible for my employees, as well as a transplant recipient on immunosuppressant medications, running a business and trying to keep everyone, including myself, safe. I have been dealing with kidney disease for more than 30 years. I was on hemodialysis for 19 months before receiving a kidney transplant, a living kidney from my sister, over 25 years ago in this past April. I'm proud to serve AAKP as Vice President and as a member of the board. Being part of AAKP allows me to represent other patients with kidney disease by talking to U.S. senators and representatives on key issues affecting kidney patients. It also allows me to meet and interact with members of other kidney-focused organizations, as well as pharmaceutical and medical technology companies, with the potential to help kidney patients in the future. Today, I am pleased to introduce Dr. Olivia Cates from Tufts University School of Medicine in Boston, who will present on coronavirus, treating immunosuppressed population during a global pandemic, dialysis and transplantation. We appreciate Dr. Cates for her taking the time to share insights on treatment of immunosuppressed populations like kidney patients during the COVID-19 pandemic, and how timely research and innovation can improve patients' lives and society.
Hello, and thank you to the AAKP for the opportunity to present. I'm Olivia Cates, a third-year fellow in infectious diseases at the University of Washington. I'm honored to be sharing what I know about COVID-19 in kidney patients, specifically in patients on dialysis or with a history of kidney transplantation. I have no conflicts of interest to disclose. I'm going to begin with patients on dialysis. I think that we should try to understand these folks as patients often with multiple chronic illnesses, end-stage kidney disease, its causes and its complications, and very frequent contacts with the healthcare system. So those might be the reasons that COVID-19 is more common in patients on dialysis than in the general population. For example, more than 4 times as common in dialysis patients in Wuhan, China. Frequent contacts with healthcare staff and with other patients are inevitable in the dialysis center. In this model from South Korea, dialysis centers used risk-based screening to triage patients to multiple different treatment settings based on whether they had been in contact with a case of COVID-19. And this program was very successful at reducing transmissions in the dialysis center. In some programs, screening has instead been based on symptoms, and in China, many dialysis centers have moved to universal testing of all patients at regular intervals. But it's important to remember that the risk of exposure extends beyond the dialysis unit. For example, one study from Spain found that 67% of their dialysis patients who developed COVID-19 used some form of shared transportation to get to their dialysis appointments. Patients may also have to attend appointments or receive urgent care related to their dialysis access. Many patients may wish to continue with the steps of a transplant evaluation, and dialysis centers have to consider how used dialysate and other waste will be managed, and how staff will be protected, screened, and potentially isolated. With early descriptions of COVID-19, we saw a lot of variability in the reported rates of certain symptoms, like fever or gastrointestinal symptoms. Over the course of the outbreak, it's becoming apparent that these symptoms really are not very different for different types of patients. Instead, a lot of that variation was likely explained by the different types of measurements being used. For example, did you ask the patient if they felt feverish? Did you take their temperature just once? Or did you take their temperature several times a day, every day during their inpatient stay? Patients on dialysis have similar symptoms to other patients. About half will have fever in the very beginning of their illness, and most, but not all, will have cough or shortness of breath. As I mentioned, some countries have implemented universal testing of their dialysis patients and have found that between 20 and 40% of patients who test positive actually have no symptoms. This is also similar to the general population, where very broad testing has been implemented in South Korea, 30% of positive patients are asymptomatic. Another statistic that seemed to vary quite a bit is mortality. First, in the United States, Johns Hopkins COVID-19 dashboard estimates that the overall case fatality rate is around 6%. That number comes from national testing data and cause of death data, so it includes the largest denominator, but it's prone to some errors from miscategorization and delayed counting. The next set of estimates here are observed case fatality rates from medium to large studies of hospitalized patients with COVID-19, and these range from 8% to 33%. The lighter bars are patients who were still hospitalized in these studies at the time the data were analyzed, so it's not clear whether those patients will survive to discharge. And at the bottom is mortality for hemodialysis patients with COVID-19. These range from 16% to 34%. Clearly that's higher than the Johns Hopkins estimate, and it's higher than some, but not all, of the general population observed case fatality rates. I just think it's helpful to recognize that the appropriate comparison is to other observed case fatality rates and not to model estimates. So dialysis patients are at high risk for getting COVID-19, and their mortality from COVID-19 is high, although we have to be careful when comparing observed case fatality rates to population-level model estimates. Now we're going to look at the same information for patients with kidney transplants. And like dialysis patients, patients with kidney transplants often have chronic medical conditions. They have some healthcare exposure, although not as much as 3 times a week dialysis, and they're immunosuppressed. The biggest question about transplant recipients with COVID-19 has been what is the effect, if any, of immunosuppression on the disease process. Like with dialysis patients, we can look at estimates of the prevalence of COVID-19 among transplant recipients. These are population-level estimates from Italy and Switzerland, both showing that the prevalence in transplant patients is higher than in the general population. The data from Italy also show that the prevalence in waitlist patients, many of whom may be on dialysis, is even higher. I also want to address the role of race and ethnicity in COVID-19 risk. This slide shows unpublished data from a project that I've been involved in at the University of Washington, tracking COVID-19 cases in transplant recipients. In the UW registry, Black patients are dramatically overrepresented compared to the number of kidney transplants they receive. I've placed the UW registry data alongside recent data from UNOS for the United States and for Michigan and New York, who are the largest contributors to the case registry. These data suggest that just like the general population, kidney transplant recipients who are Black are much more likely to get COVID-19 than kidney transplant recipients who are white. This has been attributed to structural inequalities in labor, housing, and healthcare. Even though kidney transplant recipients in general may be a relatively privileged group, they don't appear to be protected from this effect. And like we discussed for dialysis patients, patients with kidney transplants have similar symptoms and clinical presentation to other patients with COVID-19. In several studies, it appears that the rate of hospitalization among transplant patients diagnosed with COVID-19 is around 75 to 80%, and the rate of mechanical ventilation among transplant patients with COVID-19 is around 35 to 40%. These observed rates are, once again, not dramatically different from observed rates in the general population during similar timeframes. As testing increases among patients with fewer symptoms and who generally appear well, we should see lower rates of hospitalization and lower rates of mechanical ventilation, which has already started to happen. Here's that information in plain text. Again, around 20% receive care at home, but around 1 in 3 require intensive care and a ventilator. And here's a comparison to general population observed case fatality rates. The case fatality rates we've seen in transplant recipients are often around 20%, and that certainly fits in the range that we've observed in the general population. Here's a comparison to dialysis patients on top with transplant patients on the bottom. Just like we've been discussing, in general, it looks like observed case fatality rates tend to be similar for all types of patients, although if anything, I think it would be preferable to be a transplant patient. Acute kidney injury is a common complication of COVID-19 that can have more serious implications for transplant recipients. The rate of AKI in transplant patients appears to be around 40%, and the rate in the general population is around 35%. Transplant patients may be a bit more likely to have severe AKI. 13% of patients in the UW registry required renal replacement therapy, whereas only around 5% need dialysis in the general population. It makes sense that transplant patients may be a bit more vulnerable here, Many have a single functioning kidney with some underlying graft dysfunction or chronic kidney disease, and they take several potentially nephrotoxic medications. With other respiratory viruses, immunosuppressed patients tend to shed the virus and be contagious for a longer period of time. This graphic shows all of the repeat COVID-19 tests for patients in the UW registry. There is no standardized testing protocol in this project, so these patients are probably the ones who had longer symptoms or longer hospitalizations and therefore needed to be retested. The average time to stop shedding was around 3 weeks, and the longest period reported to our registry so far has been 8 weeks, but many patients are still having positive tests. We don't know from these data if these positive PCR tests represent viable or contagious virus, but we may learn that immunosuppressed patients are also more likely to have culturable virus for longer periods, as has been shown with other respiratory viruses. So how should we be treating our patients with COVID-19? Remdesivir is an antiviral drug that was shown in the ACT-1 trial to have a modest benefit for patients requiring supplemental oxygen, but not in other groups. The supplemental O2 group in ACT-1 was the largest by far, and other groups, like patients on ventilators, would have been too small to detect a similar benefit. So just because a patient doesn't need oxygen, or just because they're on a ventilator, doesn't mean it's too early or too late to use remdesivir. It just means that there's no published study large enough to tell us if remdesivir will have a significant benefit. Unfortunately, remdesivir is not approved for patients with advanced kidney disease. The drug is also likely to be affected by ongoing shortages and issues with distribution, which we have already seen in some parts of the country. And dexamethasone has also become a candidate treatment for COVID-19. Like remdesivir, these results were first made available as a press release, and it's not always been easy to review all of the crucial information to assess the quality of either study. For dexamethasone, the results of the recovery trial have been released as a non-peer-reviewed preprint. They show that dexamethasone is beneficial for patients requiring supplemental oxygen or requiring a ventilator. They also show a not statistically significant trend toward worse outcomes for patients not yet on oxygen who were treated with dexamethasone early. If we're considering dexamethasone for kidney patients, we'll need to be careful of drug interactions with calcineurin inhibitors and of side effects like fluid retention and hypokalemia. Other immunomodulatory treatments like anti-IL-6 receptor antibodies and convalescent plasma are still under investigation. Recent study of the drug sarilumab actually showed no benefit, suggesting that these more targeted therapies may not be preferable. Convalescent plasma is still under investigation in more than 50 trials, but early findings have been very promising. It's actually not clear if it's the anti-SARS-CoV-2 neutralizing antibodies, which tend to be in very low concentrations, even in convalescent plasma, or just the broader immunomodulatory effects of plasma itself. And for transplant patients, reduction in immunosuppression has been the mainstay of management of respiratory viral infections for decades. Published reports so far mostly describe patients treated in March and April, and the majority had their immunosuppression decreased in response to COVID-19. But because a dysregulated and exaggerated immune response is actually part of the problem with COVID-19, more recently there's been interest in taking a different approach. One small study in Spain randomized patients to either reduce immunosuppression or to continue immunosuppression at the same level, and the patients who continued their immunosuppression actually did significantly better. There have also been questions about whether patients should change their maintenance immunosuppression preemptively as a way to protect against COVID-19 or to decrease disease severity. Many drugs, including mycophenolate, sirolimus, and cyclosporin, have been shown to have in vitro activity against SARS-CoV-2, but so far we've not seen a difference in COVID-19 outcomes based on what immunosuppression regimen transplant patients take at home. When we look at patients with end-stage kidney disease alongside patients with transplants, we should reflect on what these data mean for transplantation. We do not want to see patients get COVID-19 as a result of a transplant, and OPTNs currently recommend that donors be tested for COVID-19. If a patient is able to have a transplant, they may be able to avoid more healthcare contacts and potential COVID-19 exposures through dialysis. They may also become eligible for remdesivir if they do become sick, because their renal function may be improved enough to qualify for the drug. Immunosuppression, time from transplant, having a transplant at all don't necessarily seem to increase the risk of death from COVID-19, particularly when we compare transplant patients to patients who are on dialysis. Age and medical conditions, which don't change with a transplant, seem to be much more important. Transplants do require staff and resource availability and may be difficult to continue in periods of extreme resource shortages, although dialysis is also very resource intensive. In general, Medicare and Medicaid guidelines recommend that transplants should continue, even in the context of a pandemic, if they can be done safely, and personally, I agree. Living donors are a special case. Recipients may be decreasing their COVID-19 risk by coming into the hospital for a transplant and no longer using long-term dialysis, but living donors will only increase their risk. Because we have a special ethical responsibility to the living donor population, their safety needs to be prioritized. But thankfully, these transplants are usually not urgent and in many cases can be safely deferred. So to wrap up, I just wanted to highlight these key points. The major drivers of COVID-19 risk are age and comorbid conditions, which predict mortality, and race and healthcare exposures, which predict infections, and in some instances, mortality as well. Comorbid conditions, healthcare exposures, Black race or Hispanic ethnicity are all more common in patients on dialysis or patients with kidney transplants than in the general population, meaning these patients may be at increased risk. But transplantation itself doesn't seem to confer significant additional risk, and it may not be necessary or even helpful to decrease immunosuppression when these patients become sick. Thank you very much for your kind attention. I was honored to be able to present today, and I owe thanks to many collaborators, mentors, and supporters, but especially to Dr. LeMay and Dr. Fisher, who've been my partners in the UW COVID SOT Registry Project. Please stay healthy and enjoy the remainder of the Global Summit.
That was a very interesting talk, and we'd like to take this time to thank Dr. Cates for the presentation and the talk that she gave us today. Thank you, Dr. Cates.